There has been some really encouraging data lately showing quite good long-term survival for older patients receiving a reduced intensity transplant. And I think this is due to improved transplant regimens and also improved supportive care that we've developed over the years. So compared to chemotherapy only after achieving remission, alginate transplant can really offer improved survival for patients who are eligible. The decision of whether or not to receive initial intensive treatment is largely based on fitness for such treatment. And I think we're really redefining what fitness means by using a geriatric assessment to look at patients' functional status and other comorbidities to get a better sense of who would be a candidate for intensive treatment. We want to make sure not to overtreat patients who are not good candidates for such treatment, but also not to undertreat patients who we may be biased against, but really are good candidates for that type of treatment. I think the geriatric assessment is still investigational, unfortunately, and there is a lot of work being done to try to make geriatric assessment easier to do, shorter to do, and figure out ways in which it can be incorporated into general practice, most likely by using either medical assistants or nurses or other personnel to actually complete the geriatric assessment and then provide that data to the physician to help them have a better conversation with the patient. We are also having an increased focus on geriatric hematology through the American Society of Hematology, and I just wanted to mention that this is actually our third year of conducting a scientific workshop on aging and hematology at the American Society of Hematology annual meeting. So hopefully both at that meeting as well as at the ASCO meeting in June, there's going to just be an increased amount of data coming out about how to treat older patients with blood cancers. Most notably, there's a drug called CPX-351 that was actually shown to provide better overall survival compared to our standard therapy for patients with secondary type of AML. And 7 and 3 has been around since the 1970s. Many attempts have been made to improve upon it by adding drugs to it, and those have largely been unsuccessful. So I think once CPX-351 receives regulatory approval, it will be a new standard of care for patients with secondary AML, and we're really excited to get that drug into practice.